Dr. Prashant, you can start your session.
Thank you. Hello, doctors. Good afternoon. Welcome to this webinar on the role of Oseltamivir in flu management. This webinar is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, the journey began in 1993. We have 30 years of excellence and 36 state-of-art manufacturing facilities, 300 plus products and portfolio, and presence in 126 plus countries. Hetero Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. Hetero Healthcare is among the largest manufacturers of ARV, APIs, and FDFs in the world. Hetero Healthcare has Asia's largest API manufacturing facility at SEZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is a 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India. With wide product range encompassing multiple specialties, Hetero Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirus, offered oseltamivir, favipiravir, and remdesivir to the patient, because of which in August 2020, Hetero Healthcare received an award for pharma excellence for COVID drugs. Today's webinar, role of oseltamivir in flu management. We have got moderator Dr. Anil M. sir. Welcome, Dr. Anil.
Thank you,
Dr.
sir.
Anil M. is MBBS MD Pediatrics with fellowship in Pediatric Critical Care, Diploma in Allergy and Asthma. Sir is lead consultant Pediatrics and Pediatric Critical Care, Spurs Hospital, Bengaluru. With this brief introduction, I hand over the session to Dr. Anil. Over to you, sir. I stop
Yeah.
sharing my slides.
Thank you, sir. I'll start sharing my slides.
Yes, sir.
Yes, sir. Is it seen, sir? Slides?
Yes, sir. Clearly.
Yes, sir. Thank you. So, thank you, everyone. A very warm good evening to everyone from Bangalore. So, today, in the next 30 to 40 minutes, we will discuss this very important topic. That is, we are going to talk on the role of oseltamivir in the influenza infections and management of influenza infections in general. Me being a pediatrician, probably I'll focus more on the pediatrics. And of course, the same thing is applicable to general population also. So a brief introduction as to why we are talking about this topic today. So probably over the years, what has happened, we have been seeing more and more bacterial infections, the vaccinations we have been doing for majority of these bacterial infections. Vaccination is going on for PCV. We are covering most of the preventable diseases. And now what we are seeing is slowly the number of viral infections has started picking up. Same thing we experienced this year also. We had waves and waves of these viral infections, different viral infections, out of which influenza virus is a major presence was felt in the last couple of years. So over the next 30 to 40 minutes, we will discuss about this. Briefly, we will touch upon the influenza virus, very basics of it, how the transmission of influenza happens, what is the background, why is this become so important, and what is the current situation that is happening in India. Also, we will talk about how to categorize this influenza illness according to the Indian Academy of Pediatrics or the government given Ministry of Health and Family Welfare criteria into category A, B, and C. Also, we will briefly touch upon the clinical management of each of the categories and also the red flags, what we need to watch out for. And then the main focus for today will be on the molecule oseltamivir, which we have been using. We will discuss briefly how it works, what is the mechanism, and how effective it is. Also, we will discuss few cases. We will look at the practical treatment protocols, what difficulties we come across while managing this flu, and the severe cases and what precautions we need to take. We will discuss about these basic things. So to start with, influenza virus. So this is the virus that we are talking about today. So if you look at the structure, this is an RNA virus. So inside we are seeing the strands of the ribonuclear protein that is there inside. And there is a capsule here. And on the capsules, we are seeing two types of glycoproteins. So the prominent ones are marked here in blue, that is a hemagglutinin thing, glycoprotein. The second one is marked in this red color, that is called the neuraminidase. So hemagglutinin, when we talk about influenza, you would have heard about H1N1, all this. So this is where the H is coming from, and this is where the N is coming from. So hemagglutinin H stands for the hemagglutinin glycoprotein, which is there on the envelope. N stands for the neuraminidase, which is there on the envelope. So the RNA is there inside. So this is the virus that we are talking about. So the different names, terminologies are given like H1, H2, H3 based on this, N1, N2, N3, and so forth, based on the structure of this particular glycoprotein. So there can be a different combination of H1, N1, H3, N2. So these are the things which are going around right now. And this is how the nomenclature is chosen. And this variety keeps changing. There is shift in these antigenic structures or the protein structures each season. So each season we see that the structure will keep changing and the combination will keep changing. And a different or a new strain will keep on emerging on a yearly basis, or in each season we see that there can be a different combination of this virus. So we discussed about H and N. What is the importance? So H, hemagglutinin protein, is important for the cell entry, to get stuck to the host cell. In the sense, once the virus comes, it has to gain entry to the host cell or the human cell. This is where the H glycoprotein is important. And the N glycoprotein, that is the neuraminidase, is important for viral release. So it enters the cell, multiplies, and for release, the neuraminidase is important. So this is more like a molecular scissors, and this is more like a glue which comes and attaches to the cell. So this is about the basic structure of the influenza virus. So now let us spend some time looking at the transmission route. So what are the routes of transmission? There are three important routes. One is called the droplet, aerosol, and by direct contact of contaminated surface. So if we look at the way this virus is spread, so the most important is the droplet spread. So this is where particle size of more than 5 micrometer is spread, and these droplets can travel to less than 1 meter. So by coming in close contact with an infected individual within 1 meter, that's why when we say take precaution, we need to stay away more than 1 meter from the infected person. So you should maintain the distancing. That is why we were told to maintain social distancing during the COVID pandemic. So to avoid these direct transmission by droplets, we need to stay away more than 1 meter. So the second method is by aerosol. Aerosol in the sense when these droplets become very small droplets, that is less than 5 micrometer, these can travel for beyond 1 meter, it can go. Okay. So these can travel for beyond 1 meter, can become airborne, and can affect the susceptible individual. So these are the two ways how this will spread. One is through a droplet, direct droplet, and if it is becomes airborne, if it is very small. The second way it can spread is through direct contact. So by touching the infected person, by handling the respiratory secretions and all, so there can be a direct contact spread. It can also happen through the fomites. Fomites andre, through the bed, by touching the doorknob, by touching the surfaces. So all these droplets can stay on the fomites. Those are the non-living things which are there. And by touching these things, we come in the indirect contact. So this is how the virus spreads from person to person. One is a direct droplet spread. This is most important. Once it becomes airborne or through contact, which can be direct or indirect. So this is very, very briefly about the virus. the structure of the virus, and how the transmission happens. So the next few minutes we will spend in understanding the current situation, where do we stand, and over the years what has happened. So if we look at this historically, what has happened, uh, in 1918 itself, there was a huge outbreak causing lots of deaths, almost 50 to 100 million deaths. Probably then the technology was not advanced to find out what virus it was, what kind of category it was, but still, historically, we know that in 1918 there was a huge, great Spanish flu pandemic which spread across and caused lots of mortality. And probably all those people who are practicing medicine now, we are more well versed. We know what happened in 2009, where there was an outbreak globally of this H1N1, which led to a lot of deaths in 2009 also. And annually, this kind of keeps going on, causing to lots of deaths. Almost 300 to 600,000 deaths are caused because of this influenza virus. So historically, if you look at this, the Great Spanish Flu was because of this variety of virus, that is the H1N1 variety. H2N2 was detected as early as 1957. H3N2 variant was there in 1968 and so forth. And we are more concerned what we saw in 2009. There was re-emergence of H1N1 and now it has become endemic, means we are getting this on a regular basis, this variant of the virus. So that is about history as to what has happened previously. Currently, if you look at India, so we usually get this in two seasons. One is the majority or the bigger peak, we get it in the monsoon season. So monsoon season in India will last somewhere June, July in South India, and then it goes on August, September, October towards early November. This is the first peak or the higher peak which happens in the monsoon season. And then the second peak happens around now. We are seeing little increased cases of flu or the respiratory infections coming now. So exactly we are mimicking this. There was little lull season in November, December, and now slowly it is picking up now. So January, February, March, April, probably for little longer in North India, where winter will be there for a little longer. And then once summer comes, it will come down. So typically that is how bimodal incidents. One is during monsoon season, the second one happens during the winter season. This happens. So even in Bangalore, we are getting almost a similar kind of occurrence. So the first peak we get it in the monsoon season, and then there is a small second peak which happens around now. That is the winter season. We are seeing this similar picture happening. So now we know what is influenza virus, when it happens, and then we will look at when to suspect influenza infection. So classically, what we see influenza, what commonly we keep calling flu symptoms. What are these flu symptoms? These are the typical OPD patients that we see in our OPD. They come with fever, cold, cough, sore throat, severe body pain, headache, tiredness. All this will come. Suddenly, if there is a change in our OPD, in the sense, if the numbers are increasing suddenly, there is a background of monsoon season or in the winter season, suddenly the number picks up. Similar patients start coming to us, then we know that, okay, something is happening, some viral outbreak is there. So that is when we start suspecting influenza. But influenza is not like the common cold. The symptoms are much more severe. The fever is a very sudden, abrupt onset. Very high fever will be there. And the other symptoms, like your sore throat, can be very severe sore throat. The cough, especially dry, non-productive cough, is what they complain with lots of sore throat. The fever becomes, it's a sudden, abrupt onset associated with chills, and there are respiratory symptoms. They can have runny nose, stuffy nose, and with a non-productive cough. This is when we suspect flu. And also there is general symptoms like severe body pain, headache, fatigue, loss of appetite, and severe pain around the eye will be there. So especially when this flu season is happening, we should not forget our old friend dengue fever, even though the symptoms can be because of similar symptoms sometimes we see because of dengue. So always keep in mind a differential diagnosis of dengue fever on first few days when the respiratory symptoms have not started. We sometimes it can go missing. What about the other viruses? Yes, of course, we get the other viruses also. We can clinically differentiate if we get the enough clues. One is RSV virus. So usually this also happens in epidemics. Suddenly there is outbreak of RSV, but this is a gradual onset. It's usually in smaller babies. They'll come with lots of wheezing and respiratory issues, more like bronchiolitis kind of a presentation. Yes, rhinovirus, again, these viruses are generally mild, not much of fever, it's a localized virus. And there can be para-influenza virus. So mind you, in the name there is influenza here, but this is a para-influenza virus. This again happens in children. They come with stridor, like croup kind of a presentation, and less of systemic symptoms are much lesser in para-influenza virus. And whenever we are taking history, we should make sure exposure history, like anybody else in the family is affected or not, we should see. That will give us a very important clue. So in a nutshell, so we should always keep our antennas open for diagnosis of flu. Whenever there is a sudden onset fever, very severe symptoms like body pain, headache, sore throat, and respiratory symptoms, especially in the background of the seasonal variation, we should be suspecting flu kind of an illness. So this is our next section where we discussed about when to suspect influenza. This is the clinical scenario. So we have suspected influenza. So how do we go about managing these patients? So this one we will look at in the next few slides. We usually categorize them into category A, that is the uncomplicated or a mild illness, category B, which is little bit more moderate or a severe kind of illness, or will include the high risk people here, and category C, who are critical or very severe cases. So this categorization is given by Indian Academy of Pediatrics, and also the Ministry of Health and Family Welfare guidelines are there. So category A, let us look at. So category A patients are the mildest of the patients that we see in our OPD patient. So with all the symptom signs we discussed, the patient is brought to us. The child is still active between the fever. There is only a little bit of symptoms. Child is still able to take orally well. So these are the ones who are uncomplicated. So they can have fever, cough, sore throat, body ache, headache, and sometimes they come with diarrhea or vomiting symptoms also, which can be seen in few patients. Here, the management is only symptomatic because influenza is a self-limiting illness. 4 or 5 days, things will get better. So we give them paracetamol as much as possible. Hydration is important and rest is important. Here, we should stress upon home isolation whenever the flu is season is going on. So these patients should isolate themselves from home, especially from the high risk contacts they may be coming. So this will just with symptomatic supportive care, these category A patients will get better. But always we should educate them about the red flag signs. When to come back, we should tell them. We should tell them whenever these red flag signs are there, which I'll discuss, please come back to the hospital after 24 hours, 48 hours. We will check them again. We should tell them, reassure them, and send. This category of category A, there is no need for hospitalization. So testing is not required. No need for specific therapy like Oseltamivir, and testing is definitely not indicated and not required for mild cases. Definitely not required. So now we'll move on to a little bit more complicated scenario. This is the category B. So here it is little bit more than the category A symptoms. So they can have moderate to severe symptoms can be there, or because of other problems they have, these patients may be already at high risk. First, we will discuss about the high risk. Whom do we call high risk? any children, especially infants less than 6 months, are considered high risk. So usually anybody who is less than 2 years are high risk. Specifically, we should look at infants less than 6 months, or they have any other chronic diseases. Chronic diseases means they can have a long-standing asthma, COPD, they have a cardiac issues long-standing, or they may have any kind of immunocompromised status because of steroid usage or other systemic illness. Nowadays, we should not forget obesity and also long-standing neuromuscular diseases. So all these patients, because they're already at high risk, they directly fall into this category B. So compared to category A, so the severe symptoms, that is very high fever, severe sore throat, little bit of respiratory distress, significant myalgia, means when the symptoms are more, they were categorized as B1 category. High risk will come in B2 category. So in this situation, hospitalization may be required. So here we have to categorize based on case to case basis. We need to see if they're more tired, more having risk factors. Preventively, we may have to hospitalize them. Here, specific antiviral treatment, oseltamivir, is very much required, and testing is required. If it is available, please get the testing done in the category B kind of patients. So let's look at the last category. That is, it is self-explanatory. Much more sicker patients are called category C patients, where they're critical or they're requiring ICU kind of support. So these patients will require an immediate hospitalization. Some of them will land up directly in the ICU. Why do they land up over here? If you look at all these systemic things, so respiratory system wise, they may have difficulty to breathe. They may have severe chest pain, stridor, cyanosis, oxygen requirement, and all that. CNS wise, children may have very tired, altered mental, very drowsy. They can have seizures, encephalitis, confusion, all these things. Or they may be hemodynamically unstable. That is, they're hypotensive, they're in shock, or they have secondary bacterial sepsis. And any complications because of the systemic problems like pneumonia, myocarditis, or they can have a multi-organ involvement. And if they're requiring ICU kind of treatment, these are in category C. Here, of course, we need to test mandatorily. We need to test them for the flu. And of course, there's people are started on oseltamivir empirically, means even before the testing is done, even before the results are available, we don't wait and lose the important time. I'll tell you why later on. So these cases will require immediate hospitalization, immediate testing, and immediate empirical starting of this molecule, oseltamivir. So now we saw that in category B and category C, we saw that oseltamivir is very much required even empirically. So now we will very briefly look at how is this working. So this is a very brief understanding of structure. First, what happens? The virus comes, and this is the virus which has the red projection like this. That is the on the surface, which is the hemagglutinin, which has the green projection, which is called the neuraminidase. So this is the virus particle over here. So this particle gets attached to the cell over here. So what is the thing which is attaching is the red projection. So red projection is nothing but hemagglutinin. So virus will get attached. It will go inside the cell. This is the human cell. It will go inside the cell and it will multiply in our cell. Once the multiplication happens, the daughter viruses are released. So this RNA is packed into an endosome like this, and then once it matures, it is released. So for releasing into the thing, see here, this part, if you see, so the green thing, that is a green glycoprotein, is the neuraminidase, is releasing the daughter cell into the circulation. So by blocking this neuraminidase, you see all these black dots here. This is the oseltamivir molecule. It will come and block the green scissors so that this cell becomes attached with the cell, won't get released at all. The release doesn't happen. So this virus particle is sitting on the cell itself. By doing this, what happens? It prevents the traps the viruses on the infected cell surface and stops spreading to neighboring cells. So the viruses are trapped over there. It is not released at all. So because of all this, what happens? There is reduced viral shedding. Number of viruses circulating in our body will become very less. And because of all this, the symptom duration will come down by 1 to 2 days. Number one, the spreading is less, so the complication risk will become very less by starting this medicine, and the symptom duration will also become very less. So whatever would have become into category C, we can halt them in category A or B itself. So this is how oseltamivir works. So very simple. It will lock the virus particle along with the cell, infected cell itself, by inhibiting the release. So that is how it works. So that was about how it works. And then how much should we use this oseltamivir? So it is given very nicely here in this table. For treatment, it is 2 times a day. For prophylaxis, it is 1 time in a day. Okay. Treatment is for 5 days. Prophylaxis is for 10 days. Okay. So prophylaxis means prevention. For prevention, it is for 10 days. This is for all the contacts. And for children, it is in the weight bands. So if you remember this, less than 50 kg, it is 30 mg twice a day. 15 to 23, 45 mg. 23 to 40, it will be 60 mg. And more than 40 kg, it is 75 milligram 2 times a day. Already we discussed the benefits of starting this early. So whenever symptoms are there, we should start within the first 48 hours. That is very, very important that we start the first 48 hours itself, because by doing this, spread of virus in the body is limited, complications are less, and the recovery is much faster. Okay. This is about how to use it and what is the dosage. Now, if you look at the safety profile and precaution, how to go about this. So it is generally a very, very safe drug. Usually we don't get much of side effects. In children, sometimes we get nausea, vomiting, and self-limited. Usually first dose, second dose, this happens. And if they continue, usually they tolerate it well. They can have little GI symptoms like abdominal pain, bloating, vomiting, and usually it's the first few doses it is there, and then it will settle down. Very rarely these rarer side effects are there, which we usually don't come across. Resistance, usually there is no way to check this resistance, and till now majority of the strains are quite sensitive, and this molecule is safe to be used in pregnancy also. So if you look at it, it's a GI side effects. This is the most important thing. So that was about the side effect profile. Now a word or two about the precaution, how to prevent this, and how to what advice do we give for the patient. See, the most important advice for the patient and for ourselves, for healthcare facility people also, is to take an annual vaccine, flu vaccine. The virus itself keeps on changing every year. So by taking this vaccine, which includes the latest viruses which is going on in the community, we can prevent this happening of this flu. So it is very important that all of us take, and we also advise all of our patients to take it. And for the patient, when they are coughing or going near a patient, wear a mask, keep a safe distance, make sure the droplet spread is prevented by sneezing or coughing into a folded arm, frequent hand washing, avoiding crowded spaces. See, these are the general things what was told to us during COVID. So we should do all these preventive or a precautionary measure for the patient. And for ourselves as a healthcare practitioner, yes, most important we discussed is the vaccine, keeping safe distance, wearing appropriate personal protective equipment, which may be an N95 mask or even a simple face mask is important. Keeping our hospital and clinic well ventilated with a cross ventilation is very important. Practicing good infection control measures, frequent hand washing between the patient, it's very, very important. So not just the treatment, we should also educate the patients and also ourselves about the precautions and the safety measures that we take. And now we discussed category B and C definitely require treatment with oseltamivir. And especially we talk about empiric therapy. Empiric means when the suspicion is there, we don't wait for RT-PCR reports. We go ahead and start them on this. We already discussed twice a day for 5 days is the treatment, whereas prophylaxis is once a day for 10 days. And ideally started within 48 hours of exposure. This works best. Okay. So let us look at few case scenarios like how we do it on ground or in on the field, how we work. For example, we had this 14-month-old patient who was referred to us, was deteriorating, requiring oxygen, respiratory distress, requiring PICU admission. So whenever in the season we get such a patient, we don't wait on this patient. So if the child is sick, definitely we will admit in the ICU. We will do what is required. In the sense, general supportive care is always there, treating the fever, giving nebulization for the cough, managing with supplemental oxygen or respiratory support is definitely done. But what is more important is empirically we are starting whenever we are getting a sick patient. We don't wait for the swab report because that may take like 1 or 2 days for the report to come. So empirically we go ahead and start them on oseltamivir. And example for this patient, swab was sent on day 1, H3N2 came positive. Some situations we are lucky to get it on the same day, but not every place this swab testing may be available. So in such situation, please we'll go ahead and start this child. This was child was started on oseltamivir empirically. So this child improved without going into much complication. So even though we do all the general supportive measures, the specific treatment of starting empirical oseltamivir, I'm highlighting by this case. And there's one more scenario that is about prophylaxis. How do we take care? For example, we had this 3-month-old infant where mother had influenza, severe kind of an influenza. So since this is coming into a high risk contact, less than 2-year-old, so this child was started when the mother is having influenza, confirmed influenza. So this comes in high risk because of the age. So here we started as soon as the diagnosis was confirmed. Here we give it for 10 days. So this child never developed any illness despite close contact. So we should make sure and extend the benefit of the prophylaxis to all the high risk contacts. But again, please highlight this that this is a high risk contact, not for a healthy adult, but anybody like what we discussed in B2 category, high risk category will require to be started on this molecule. And always initiate it early, complete the full 10-day course, and this will definitely prevent the disease burden in the high risk group. So what other problems we come across when we are managing somebody on this molecule? What are the common questions or doubts that we may have? One is how safe it is, or if the child develops vomiting, how do we take care? Like I mentioned, usually it is self-limiting in the sense after 1 or 2 times vomiting, it will settle on its own. Or many a times we don't come across this problem at all. So sometimes we advise them to take it along with food or break it into small parts and administer it more frequently. And very rarely we prescribe this proton pump inhibitors like lansoprazole, or sometimes prokinetic agents are prescribed. But just because there is vomiting, please do not discontinue therapy because this will settle down on its own. So please continue with the treatment and complete the full course. So we discussed that the best effect is if it is started less than 48 hours. So what about patient if they're referred to us or if they deteriorate after 48 hours, what to do? Yes, even in such situation, please go ahead and start them on empirical oseltamivir if they're sick and coming in the season, because even if it is delayed, there is definitely clinical benefit. We just saw uh, how useful it is. It prevents the spread of the virus. So it reduces the complications. So even if it is there, please go ahead and uh, start them on this molecule. Is there any resistance which is documented? It's very difficult to document resistance for this virus. So far, the clinical outcome is very good. There is no documented resistance to support to tell that there is resistance. So we assume that as of now, all isolates are susceptible, and usually within the second day, third day, there is a clinical response. Okay. If there is no response within 2, 3 days, then we look at other factors. Is there a secondary bacterial infection? Is our dosing adequate and all that? So here also we continue with the treatment, full 5 days treatment. So takeaway messages out of all these things that we discussed in the last 30 to 40 minutes. Please recognize this condition of influenza illness. Recognize the seasonality of it. One is just before monsoons or after the monsoons have started. Second peak is in the winter. So have your antennas up and diagnose the flu cases in the season. So typical pattern is sudden onset fever, myalgia, headache. Always the suspicion has to be very high. It's very easy to manage these patients. If you use this IAP and the MOHFW category, we can categorize them into A, B, C and manage it very easily. Starting treatment in such a category B and C, it's very important. Empirically, as early as possible, we need to start treatment within 48 hours. So just because swab is not available, do not delay the treatment. So go ahead and start treatment. Like we discussed, it prevents the viral spread and the complications. So it is very important molecule. Weight-based dosing has to be given for 5 days. Also, word of about precaution and prognosis should be explained both for the patient and our own staff. So respiratory isolation, wearing appropriate equipment, personal protective equipment, hand hygiene, and how to reduce transmission we should know. Also, not just treating the patient, prophylaxis for the high risk contacts, it's very effective. So please make sure of it. Do it early in the illness, and also a timely treatment will give a best outcome. So in brief, this is the key takeaways for the whatever we discussed over the last 30 minutes. This is the key takeaway. Thank you all for your patient listening. Thank you. If there are any questions, we can take it up.
Thank you so much, Doctor. It was a wonderful session. However, I just wanted to ask you one thing since you mentioned in your summary slide that, a flu is seasonal. There is a peak from Jan to March, and then we again see it from maybe June to August. But we see that there is constantly season change that has been happening. Climatic conditions are changing. So, does this impact the flu season, or can we now say that is it no more seasonal, or what is your take on this?
Yes, in those seasons, we definitely see the peaks. In the other times also, it is there in the community, not that it is completely gone. Only because of the seasons, the numbers are much more in those seasons. So what we call as an epidemic kind of a proportion is reached in that season. But in other seasons also, there is flu which is going on in the community. But the peak is happening in those 2 seasons.
Right, absolutely. Thank you so much, doctor, for your insight and for your time. I
Yeah.
also thank all the doctors who took out their time and attended this webinar. I'm sure it must have had an impact, and we tried to show the role of oseltamivir in flu management as rightly described by Dr. Anil. So thank you all again. Have a wonderful day ahead. Also, thanks to Sanjana IT team for conducting and scheduling this webinar. Have a great day, everyone.
Yeah. Thank you all. Thank you, everyone.
Thank you, doctor. Thank you, Sanjana.